I am Eli Smith, a psychology student diagnosed with bipolar 1 disorder. I'd like to share a few facts about how we can ensure patients' comfort and clarity with a new bipolar disorder diagnosis. Why am I an expert? I'm not. I'm still an undergrad student who has a focus on research. But I stand out because of a few things. I'm willing to try. I want to help other folks like me who are in my shoes. When I first got my bipolar diagnosis, I was distraught. I knew I had a form of bipolar, but I thought that it was bipolar 2, not bipolar 1. I'm in both seats. I see how we struggle as both providers and patients. If you don't look at a problem from both sides of the coin, you don't always know the full picture. But most importantly, I understand and know that I don't know everything. I'm not a genius, and by all means, I am not a doctor yet. But I know that as providers, we have a long way to go with lowering stigmas for people with bipolar disorders. This includes patient psychoeducation, public psychoeducation, and finding medications besides just antipsychotics. Providers have to give information regarding a patient's diagnosis when it is given. There are so many times in my life as a patient that I have had to go home and research a disorder after being told, this is your diagnosis, I'm putting you on this medication. I am not given time in clinic to research a medication. I have to blindly believe what the provider is saying about different side effects and what the actual on-brand FDA-approved uses are for them. Therapists also need to play a role in psychoeducation, such as explaining how therapy and mood tracking can help manage and control bipolar disorders. Society also needs to be educated. Hollywood says a manic episode looks like setting your house on fire. And for some people, that may be true. But for most, a manic episode actually looks like spending every cent in your bank account, or being awake for a week straight, or being hospitalized because someone realizes that something isn't okay. Mania means possibly being suicidal and not realizing it because you are so high. But then there are also the lows. There is the depression where you can't get out of bed, and it's horrible for both ends. Bipolar is a disorder of highs and lows and mixed episodes. And if a patient cannot go home and tell their support system, I was diagnosed with bipolar, not otherwise specified, this is the treatment plan, without fear of being called crazy, then the diagnosis itself could trigger an episode. of the stigmas surrounding bipolar disorders are the types of medication that we use to treat it. Our golden standard is, of course, a mood stabilizer. But what happens when your patient is also epileptic, like I am? When I was put on a mood stabilizer, trileptal, I was also having seizures. The medication was not calibrated for my seizures, nor were my seizures taken into account when it was prescribed, and it made it worse. I went from having one seizure a week to having a seizure every day. And I wound up in the hospital from it. The other approved medications are atypical antipsychotics, short-term benzodiazepines, or maybe even regular old antidepressants. And as providers, we all know antidepressants do not work for bipolar. They exacerbate the symptoms. Benzodiazepines may be able to be used as a tranquilizer for a short period of time, but if you cannot be on a mood stabilizer, you have to go on an antipsychotic if you are getting treatment for your bipolar. Medications like antipsychotics come with stigmas that can make patients choose not to take it. I know that's true for me. I've been on many an antipsychotic and I cannot take them anymore. It triggers such a trauma response for me that I cannot take an antipsychotic. We have to do more research into different ways to treat bipolar and start exploring therapy options instead of just medication routes. My job today was giving you resources on how to approach stigma surrounding bipolar 1, 2, BP-NOS, and cyclothymia. Your job is to use the information to help patients. Start trying to live with one foot in each shoe. Have a seat in both chairs. How will your wording affect the life of your patient?